morning, sir. Thank you for giving me opportunity to present on this platform. My study is on decompression with or without fusion for lumbar degenerative disease. So, lumbar degenerative spondylolisthesis often requires surgery in 10 to 15% of cases where the conservative management fail, and the options include decompression alone, decompression with fusion, or fixation for instability. While research shows mixed results, with some favoring decompression alone and other decompression with fusion, long-term outcomes are under research and highly individualized and variable. So the aim of my study is to assess the functional and radiological outcome. Objectives are under categorization of pain relief, quality of life, radiological fusion, and neurological outcome. Sample size of my study is 186 patients were included. Study design is retrospective cum prospective is observational study. Duration of my study is from 2017 to 2023. Inclusion criteria for my study is patient undergoing elective surgery for degenerative lumbar spine disease and follow-up for at least 6 months. Data was collected with taking proper history and neurological examination. VAS score is used for the pain intensity, or Vested Disability Index for the disability level. Radiological assessment was done with X-ray and MRI lumbar spine. Surgical technique that is used is decompression alone and decompression with fusion, that include P-leaf, T-leaf, posterior instrumentation with reduction and posterior lateral fusion. The selection of specific fusion technique was based on the patient individual pathology, the degree of spinal instability, and the surgeon clinical judgment. Follow-up was done on first month, 6 month, 12 month, and last follow-up is as early as the pain assessment was on visual analog score. Quality of life was discussed with the Vested Disability Index. Functional outcome was by McNabb clinical outcome score, and radiological fusion was done with X-ray done on 6 month, assessed using the Warrington-Stiffy fusion criteria. So the observation of my study, the total number of patients is 186 patients. The predominant patients are male and elderly patient. 56.5% are elderly, more than 60 years. Most common complaint is lower back pain, radiculopathy. When we talk about the instability, the 43% of patients are with the instability. And when we divided the instability, then the grade 1 instability with spondylolisthesis is 87%, and grade 2 is 12.3%. Type of surgery, then the fusion go to the number of patients for the 109. When we talk about the neurological motor recovery, in my study, both groups shows a great improvement, but it is not significant. Sensory also shows an improvement in both groups, but the study is not significant. The p-value is 0.33. When we compare the VAS score, there is an improvement in pain intensity in both groups, and it is significant in first month. When we talk about the Vested Disability Index, both group shows the decrease in scoring, and it is more significant in fusion group. So the functional outcome is scored with the McNabb score, and the p-value is not significant in both the group, but the functional score is good for the both fusion and non-fusion group. And the fusion assessment is done on X-ray with Warrington-Stiffy fusion criteria. Complete fusion was observed in 52.3%. Probable fusion was in 36.7%. When we talk about the blood loss and duration of surgery, it is more in fusion groups, and it is statistically significant. And complication is more toward the fusion group with the dural tear or infection. So the conclusion of my study is neurological recovery was slightly better in fusion group with improvement in both motor and sensory recovery. VAS score, the non-fusion better at 1 month. ODI score is higher in fusion group. Outcome measures show that 57.5% of patients had an excellent McNabb score. 42.3% achieved complete fusion, 36.7% probable fusion. Fusion surgery has a more blood loss and longer surgery.
So we are, nice presentation. At the end, we are still not clear, are you recommending fusion or non-fusion?
Sir, both group shows a good improvement, but with neurological recovery, fusion group is showing better.
So, but you said on the second line, you said um, duration of surgery is longer, blood loss is more, all
Yes.
these things.
Yes,
So
sir.
after everything, what are you recommending?
Sir, in my recommendation, both are group are better, giving a better
So
result.
should we toss a coin and then decide for every patient or
No,
what?
No, sir. On the basis of instability, if there is instability, then we go toward the fusion.
Fusion, and if there is no instability, we can do without fusion.
Without fusion,
That is your recommendation.
yes.
It's nice presentation, Ashutosh. So you have 186 patients, and the follow-up is around
1 year, approx
1 year.
1 year.
So how do you assess the fusion rates?
Sir, it's on the basis of X-ray that is done on 6 months and after 6 months on Warrington-Steffi fusion criteria, that is A, B, C, D, E. That E shows the complete fusion with no gapping between the vertebra and the graft, and there is a sclerotic line that shows there is a complete fusion of the vertebra, and probable fusion that shows the gap between that is not significant, that is almost continuous, and when we talk about the uncertainty, then there is a gap that is less than 2 mm, and when there is a non-fusion, then the gap is increased to 2 mm.
Okay, and the fusion was done using the standard open surgical procedures, or minimally invasive, or endoscopy?
So with all, that is not, that done all, like MIS and endoscopic both, and open.
So it's a very heterogeneous group, and
Yes, sir,
it's very difficult to make a conclusion out of this.
Yes.
Regarding those two groups, were they comparable, like you have a fusion group and a non-fusion group?
Yes, sir.
Regarding the mobility.
Yes,
So I think all of your fusion patients had mobility, and probably all those patients of non-fusion group had no mobility.
No, no. Yes.
So obviously the indications are different.
Different.
So
Yes, this is
may-
the
they are
limitation
not
of my study.
Not the comparison group actually.
Yes, sir. Yes, sir.
If you had to compare, then either you would have compared with
Grade 1.
fixed deformity, which is not mobile, grade 1 or grade 2 listhesis with or without fusion. That would have been a better way of doing it. Or instability, obviously we don't do it because it's not a standard of care,
Yes, sir.
where we just do a laminectomy or observe. So maybe in future you can plan such study.
Yes, sir.
And how about the pain scores?
Sir, pain score improved from 8, 9 to 1.47, like this pain score.
Both the groups?
Both the groups. 1.47 and 1.4, like this.
It was comparable.
Non-significant. Yes, comparable.
Okay. Okay. Thank you.
Sir.